So I'm going to demonstrate the minimally invasive precision outrigger jig system for a distal hallux valgus correction. So the first thing we're going to do is mark the anatomy. So I'm going to feel the medial eminence, and just at the metaphyseal-diaphyseal junction, I'm going to just place a line, and then feel the first tarsometatarsal joint, which is about here, and in some specimens or patients you might not be able to feel it. So just to be sure, I'm going to place a dot and take an X-ray. So we're in approximately the right position to mark the first TMTJ. And then I'm going to feel the navicular, which is here, which is going to be our reference mark for the length of the jig. And then I'm going to set my mid-axial line of the metatarsal. And the best way to do that is feel the plantar aspect of the metatarsal, which is just at the tip of my finger here. And bearing in mind where the dorsal aspect is, and go roughly in that midpoint. And if we place a wire through the midpoint of the metatarsal head, the midpoint of our metatarsal shaft, and we're erring on the side of dorsal to this mark here, the proximal flare of the first metatarsal makes the first metatarsal appear more planted than it actually is. So bear in mind you're going to go a little bit more dorsal and then draw a line. And this line is going to help us align the outrigger in the correct position. And if you want, you can take an X-ray, lateral, placing your wire over there. Just check you're in the right place. So we're good there. So now we're going to make our osteotomy. I'm going to make a transverse distal osteotomy of the first metatarsal. So I've already marked my flare. I'm going to go in the mid-axial line and make a 3mm incision. We have the FJ2000 system here. We're going to use that throughout the procedure. And I'm going to start off with a 2x20mm burr. I'm going to place that on bone through my incision and take an X-ray. And I'm aiming to be 90 degrees or perpendicular to the shaft of the metatarsal. I think that's acceptable. 90 degrees to the shaft. So I'm just going to stabilize the first metatarsal by squeezing the 1-2 intermetatarsal space. And I'm going to advance the burr to go to the lateral cortex, but not through it. And then just take an X-ray just to check my angle of cut. So I'm heading a bit too proximal there, so I'm just going to back out and then reposition, heading a bit more distal. So we want to account for 2mm of shortening that the burr will provide. So that's a good angle for me there. So I'm now going to advance through the lateral cortex. So now I've gone through the lateral cortex. I'm now going to do my dorsal cut and then plantar cut, and this is going to be a transverse or flat cut osteotomy. So I'm going to pivot around the incision. First I'm going to do the dorsal cut. I'm going to drop my hand, and then the tip of the burr is going to head dorsally, but pivoting around the incision. And I'm going to listen to the burr, and when I hear that change in note, that's when I've completed the dorsal cut. Okay, so that's a dorsal cut. So I'm going to reinsert my burr back into my osteotomy, and now perform the plantar cut, so the opposite. I'm lifting my hand, pivoting around the incision, and the tip of the burr is heading in a plantar direction. Okay, so that's the osteotomy complete. So I'm just going to check that that osteotomy is mobile and complete, which it is. And we can just show that on the X-ray now. There's our osteotomy. So what we want to do is create a little bit of space for the hook of the jig, and we can do that in one of two ways. We can use this K-wire with a bullet nose and thickened end. I can place that into the shaft of the metatarsal, and I'm not reducing the IMA at this stage or translating the head, just purely to create some space there for the jig. The other method, if I just reduce this back, is to use the Freer elevator. There's a sharp and a blunt end. So I'm going to insert the blunt end, curves medially, just to create that space for the hook. So now we're going to fit the outrigger or the jig, and it needs to be set up in the mid-length point. There's a laser mark just here. So the jig's not too long, not too short. The hook is extended outward, and the DMAA fan correction is in a neutral position using this knob here. So I'm going to place the hook in, having the jig plantar, and rotate it up. And I'm going to just give it a tug and make sure I can't see that hook subcutaneously, which I can't. So I know I'm in bone, but I'll just take an X-ray so we know where we are now in the osteotomy. I'm going to place the drill sleeve through the green slot, and this will help align the jig in that mid-axial plane that we previously marked. And then I'm going to place a K-wire for the proximal fixation of the jig through the dorsal hole. And then I'm going to take an X-ray, and we're going to assess now the length of the jig to ensure we are close to the navicular tuberosity with this groove here, which I happen to be already. And when I take this X-ray, I want to assess the trajectory of this K-wire for the proximal fixation, because I want to go into the navicular and not violate any part of the joint. So my jig is probably a little bit too long. If I were to advance that, I might violate the talionavicular joint. So I'm going to shorten the jig length by turning this knob, and then take another X-ray, again assessing the trajectory for the wire. So that looks in a good position there. And so I now want to just again assess where exactly I'm going to place this jig. So not too plantar, not too dorsal. So I'm going to place that through skin. Just to make sure I'm on bone there. And I'm just going to look through on the lateral plane before I fix it to make sure I'm in that mid-axial plane on the jig. And now I'm going to advance my wire. And we'll take an X-ray just to check that wire is in the right place in terms of the navicular. So that's a good position there. And we'll take a lateral. And then just show the metatarsal head. I think we're better, but not quite right. So I'm going to make another adjustment, I think. Just take a slightly different view here. So I'm just going to visualize through the gap of the jig in that lateral view. And the way we're going to assess the jig angle, so not too dorsal, not too plantar, is by using the angel wing, but we'll do that in one step because we're going to fix this distally. And then we can make that adjustment with our second proximal fixation wire. So I open the gate. There's a laser mark labeled wire. I'm just going to pop this into the metatarsal head through the skin and then advance. So that fixes our jig distally. We'll just take an X-ray to check that wire's in the appropriate position. So we're close to the lateral margin of the head, roughly in the center of the head. So that's a good position there. So what we're going to do when we fix the second proximal wire, just got the feeling that this is elevated up. So I think we just want to drop the jig down. Just want a better plane in the sagittal. And the way we do that is by using the angel wing. So we want to attach the angel wing. And we want to get an AP of this angel wing, as well as an AP of the first metatarsal. So if we look at the X-ray at the moment, we haven't got quite a true AP of that first metatarsal when we look at the first TMTJ. So I think the first thing we need to do is just check. We get an X-ray at the dorsoplantar view of the first metatarsal, and we can see we've got a nice shoot through of the joint here, indicating that we are not at an oblique angle. So if I take another X-ray just to demonstrate, that's not a true AP because we can't see the first TMTJ because it's oblique, and previously we had a good AP. So then we want to put the angel wing on and change the jig angle downward, so we get both an AP of the angel wing here and the AP of our first metatarsal. So I'm just pushing on the jig downward, and what we want to see are, instead of 4 lines, we want to see 2 lines. So we can see the 2 lines in the angel wing just here, indicating we're an AP of the angel wing. Now if I was just to fix the jig in an abnormal position, we'd see the 4 lines. As I drop my hand down, we're getting the 2 lines. So now I know I need to keep that jig in a downward position when I fix it with my second wire proximally. So I'm going to pop this in the hole on the plantar hole. Have my wire ready. And what I want to do is bring that jig down and get my assistant just to drive this wire in while I hold the jig in the right position. So I'm just going to take another X-ray before we do that. Check we've got an AP of the angel wing and of the first metatarsal, and then advance the wire through the navicular. So we'll just check the second wire is through the navicular, which it is in a good position. So the jig was a little bit planter, so I've made an adjustment already. I removed the 2 wires here, and just by 3mm to 5mm moved the jig a little bit more dorsal and refixed it. So I've now taken a lateral, and the landmarks on the X-ray are the metatarsal head. This is the distal fixation pin, and to get a true lateral of the jig you want to marry up these 3 components. This is the drill sleeve for the proximal screw that we'll use soon, and then these are the threaded pins to adjust the length of the jig. So you can imagine if we fire a wire or a screw all the way center, we're going to enter into the center of the metatarsal head. And in addition, we can get a DP, or dorsoplantar view of the first metatarsal. And we can see a clear first TMTJ rather than an oblique TMTJ. I'm going to place the angel wing on. And the aim is to have a true AP, or dorsoplantar of the jig, of the angel wing, sorry, where you just see 2 lines, not 4, corresponding with the dorsoplantar view of the first metatarsal. So this is not using the targeting device as such, it's just to set the angle of the jig, which I'm now happy with. We have a uniform space, i.e. we're parallel with the first metatarsal between the angel wing and the first metatarsal itself. So now we're going to move on to correcting the deformity, and we have 4 components of that. The intermetatarsal angle, the reduction of that, the derotation element of the metatarsal head, adjusting the DMAA, and if we want to build in some compression, we can also do that as well. So the most important thing when you're translating the metatarsal head is to watch out for the metatarsal head to want to plantar flex. And I'm going to place my index finger on the dorsal aspect of the first metatarsal head. I'll just remove the angel wing just for visualization purposes. And I can feel a slight step at the osteotomy indicating the metatarsal head is plantar translated. So if I push my thumb up, that step is removed, so I know my head is in the right position. Now I'm going to start to turn this dial, and this is going to push the head laterally to reduce the intermetatarsal angle, while maintaining pressure with my left hand and my thumb to prevent that head plantar translation. So I want to achieve as much translation as possible, and the knob will get quite stiff that I'm turning now. You can always use a swab if you lose your grip. And we'll take an X-ray to assess how much translation we've achieved. So we've achieved about 95, nearly 100% translation. I'm happy with that. We've increased the proximal intermetatarsal angle, i.e. we stabilized that first TMTJ. Now we want to move on to see if we want to derotate the hallux and the first metatarsal head. I'm going to look at the nail, predominantly of the hallux for that, but also there's some radiological cues. I don't think we're malrotated, but I can make an assessment by moving the sesamoids out of the way, by twisting the toe and taking an X-ray to see if we can see the lateral metatarsal head any better. I don't think we're malrotated, so I'm not going to perform any derotation. However, I'll show you how you do that with this wire. So we open the gate here. And at the moment we're in this free space. So if I wanted to rotate or derotate the hallux, I can use these gates here by lifting up the wire and rotating the head. And I'll demonstrate that under live view. So it would appear actually that I quite like the look of that in terms of derotation. So I might just put an element of derotation in there, fix that wire in the gate, close that element to keep it secure. Now I can just fill a bit of plantar translation, so I just want to be aware of that as well. But I'm now satisfied I've derotated the head. Now I've got a slight increase in the DMAA as a consequence of translating the head over, so I want to correct that now. So this articular surface is tilted into valgus, so I want to just change that with this the DMAA correction, and I'm going to turn this clockwise. And what's that going to do? It's going to lift the wire laterally to change the correction, like that. So I'm happy now we've got two parallel surfaces at the osteotomy, here and here, whereas before this head was tilted and this angle was down here, and that's a cue to watch out for. So we've got a nice translation. The DMAA is correct. So if we want to have an element of compression, which is not usual, we can do so. If you've got a gap for whatever reason, you can shorten the length of the outrigger with this knob here. So I turn this clockwise. If you press the gold button and hold that in, that takes some slack off, and then I can turn the knob here. As I say, this is not normally needed, but sometimes it can give you an extra element of DMAA correction as you compress. So I'm happy with that position. So now we want to fit and place our proximal wire. So we're going to use the angel wing to do that. So I'll fit the angel wing back on. And here's our drill sleeve. It's loose, so I can move this in any element I want in this plane. So we want to nestle it right up onto skin. Check that my previous mid-axial mark at the start of the operation is in alignment with that sleeve, so I know I'm not completely dorsal or plantar. And then we want to have the lateral wire in the angel wing pointing roughly into the first web space. That gives us a kind of a good starting spot of where we want to be. Then we'll take an X-ray and make an assessment of. So it's a pretty good first go, but the wires are not, I can see just about 4 wires, so I just want to make sure I've got a true AP of that angel wing. And I'm pretty happy with that in terms of my proximal screw. My distal screw might be a little bit distal, but I think that's within acceptable limits. But what I can do, I can just change my entry point of my proximal wire. And another cue, I just want to get this wire central to this tube, which will give me a true reflection of where that screw is going to go. So I think I'll just take another X-ray and marry that wire up. So that looks much better. I think I'm going to take that. So I'm happy. I'm going to make sure that is nice and tight in terms of my drill sleeve guide. And now we're going to make an incision and fit our first wire. So I'm going to make my incision. I'm going to just withdraw this drill sleeve a little bit. Make my incision wide enough for the drill sleeve. Take a hemostat, just spread the soft tissues. There's often a vein here, so it's worth spreading that vein out of the way. And I'm going to advance the drill sleeve. I'm going to turn it 180 degrees so the distal part of the chamfer nestles into the wound. And then I rotate it in, and there's a little window which should be facing you. Now, you always want to check your x-ray again, because that maneuver, that push, can sometimes change the jig position. So we're just going to recheck. That we've not changed anything. So I'm pretty happy with that. The most important aspect is this entry point here. It's nice and proximal. You must penetrate this part of the lateral cortex. You don't want to be too close to the osteotomy. And we want to be in the lateral third of the head, like we are here. And this is the trajectory of my second screw. We don't want to be entering too distal, because that can be felt by the patient. And then this spike will remove later, and it gives us ample space to do that. So I'm pretty happy with that position. I'm now going to advance the 1.7mm wire for the 4mm screw. So I'm just going to gently place a little plantar pressure on the drill sleeve here, just to make sure that wire goes in a straight lateral position. So I'm just feeling some resistance there, so I think I've gone through. So we'll just check. So I need to advance clearly further into the head. Okay. So I'm just going to take my angel wing off so we can just have a look and see. So I'm just going to take an x-ray to show the K-wire placement now, just to confirm we're in the right position, which will obviously be replaced by the screw. So we've got a good entry point here at the base of the first metatarsal. We're purchasing through this lateral cortex. We're not too close to the osteotomy. We're in the lateral third of the metatarsal head. And our translation and correction has been maintained. And we can just take an x-ray on the lateral position, just to check we're in the head appropriately. And we can see that the drill sleeve, the wire, and then the wire extends, and we're in the center of the head. So happy with that position. So now we're going to place the wire for our distal screw. I'm going to place it in the pink slot and make a small stab incision, and just spread with a hemostat, and then place the drill sleeve onto bone. I'm going to put a 3mm screw in here, so I'm going to use the smaller wire. So it's important not to push too hard, just to reduce the risk of anything skiving off. And I place my thumb on the end of the drill sleeve. So I've just felt some resistance, and sometimes you might encroach on the distal fixation 2mm K-wire in the metatarsal head, which I have. But I'm happy with that, that distal screw position. It's appropriately proximal, it's not too distal, and it's just skived off of that lateral margin of the shaft, which is absolutely fine, and we're in the lateral third of the head. It's not so important, this screw, in terms of the position in the head. So we just want to see if we can navigate past that wire, but we can always take that wire out now, as we've got good temporary fixation with the proximal wire. So it's directly on that wire, so I'm going to take this wire out. And then advance. So we'll take another X-ray just to check that position of our distal wire. So I'm happy with that. Okay. So now we're going to drill for the 4mm screw. So I'm going to unscrew the K-wire sleeve, and on the FJ 2000 system, attach the AO couple, to which we have a drill attached. So I've gone through the lateral cortex and then into the head. So now I'm going to measure for the screw. I'm going to place it on bone. We can just check that we are on bone with that measure. And we can just see the shadow of the measure just here on bone. I'm also checking that my wire hasn't changed position. So now I'm going to insert the screw, place that over the wire into the sleeve. I have the hexalobe driver on power initially. This will just slot in exactly where it's needed in terms of the orientation of the chamfer. And there's a laser line at the base of the shaft, and I marry that up with the drill sleeve to know that I'm seated flush with bone. So in hard bone like this, I'm going to go a bit more cautious. And do the rest by hand. But in softer bone, at low speed, particularly when you purchase through that lateral cortex, that's safe to do that, but I would always finish it off by hand. So I'm going to just engage the screwdriver. So I'm going through the lateral cortex now. It's nice, hard, strong bone. I can hear that little squeak. And we have a laser line, not only to know when we've bottomed out on the screw, but also the orientation of the chamfer. So when I get to that laser line, I'm going to stop and then make sure I can see the chamfer laser line. So we don't need to continually need to X-ray as we're screwing. We'll be there or thereabouts. So just going to advance that a little bit more. Now there's a nice little window in the proximal drill sleeve, and it allows me to see the laser line through it. So I'm just going to get my orientation referencing off of that. And then we've got a well-seated screw. It's flush with bone here, not proud. Got excellent head purchase around the lateral third of the head. I'm not too distal. And that's going to give us a very reliable and strong fixation. So I'm going to take that drill sleeve out, that's no longer needed, and the wire. Okay, so now we're going to drill. Place that drill sleeve back on that the distal screw. I'm going to drill for the 3mm screw. So this is a derotation screw. And we're going to remove the sleeve. I'm going to take the jig off before we measure. So what we do is take the wires out, the proximal fixation, and because we've got the screw in place, you know we've got a nice stable construct now. So we can just loosen everything off in terms of the corrections. Let's see if we can work around this wire. I'm going to measure. This is the distal screw, which is going to be 3mm. And again, if you want, you can take an X-ray just to ensure we are flush with bone there, which we are. Measuring 44, we're just close to the joint, so I'll probably take 4mm off and put a 40 screw in. So we place our screw on the wire. Now we do have an option. You can either put the screw in like this. You've got the potential to traumatize the skin, so ideally you want to protect the skin. So we have a tissue protector. We can just place that in the wound to protect the skin. And then initially on power. The bone's quite hard here, so we're going to be a little bit careful and finish off by hand. And again, noting the laser line, which is where our chamfer is going to end up. So we want that facing upward towards us. So we'll take an X-ray and check. So probably one more turn. There's a potential, even for a small amount of screw to light outside of bone, it can be palpated, particularly in patients which don't have much coverage on the foot. So I think I'll just go 2 turns more, which is another couple of millimeters of advancement. So now we've placed the distal screw. We'll just check our X-rays. So very happy with that translation. Rotational correction. The screws are in a good position, so the proximal screw seated within bone, penetrating that lateral cortex in the lateral third of the metatarsal head. So our 3mm screw is a derotation screw. We're penetrating nice and proximally, not encroaching close to the osteotomy where it could be felt in the lateral third of the head. And we have this spike, and we're going to remove that in a moment. But let's just check our lateral position. So got a good position there of both our screws. There's no plantar flexion of the metatarsal head, so happy with that. So now we'll turn our attention to removing the spike. So that's the position we want to remove the spike. We want to be parallel with the distal screw, leave bone around that distal screw so it doesn't become prominent or exposed, and enough to remove the spike so it won't be palpable. So we'll just check the osteotomy now. And you've got two options. You can push the bone in, and you can normally do that with slightly softer or more osteoporotic bone, or in harder, younger bone, you can actually remove the spike. And I can actually feel it slightly prominent, so I'm going to remove it. So I've removed the spike. We've got bone surrounding the screw here. The spike's gone. It can't be palpated. It's nice and smooth on this side. I then assess for any residual hallux valgus and perform a lateral release if necessary. Again, assess for any residual hallux valgus in a weight-bearing position and perform an Aiken osteotomy as required.